So, every wound is hypoxic, but not every wound is ischemic. Hmm. So, welcome back to Diabetic Foot Files, where we are bridging cutting edge science with real world diabetic limb preservation. So, today we're going to be covering a misunderstood concept because I kind of covered a little touch of it yesterday, but people often use the term hypoxia and ischemia interchangeably, but they're actually quite not the same. And understanding the difference may completely change how you evaluate a diabetic foot ulcer. Because if you mistake ischemia for hypoxia, you may spend months applying advanced wound care products like hyperbarics, growth factor skin substitutes, and the wound still never heals. But regardless of anything, you would need vascular, okay? You need vascular. That would help avoid that problem if you get vascular. Yay, love vascular. So let's go to a brief history of that. So, ancient understanding, thousands of years ago, physicians knew tissues could die, but they didn't understand exactly why. Hippocrates described gangrene. Galen recognized loss of circulation after trauma, yet oxygen itself was not known. So, in 1774, Joseph Priestley isolated oxygen. Antoine Lavoisier later discovered oxygen's role in respiration, and then suddenly physicians understood that life depends on oxygen. Rudolf Virchow in the mid 1800s, Virchow revolutionized pathology. He recognized that disease begins at a cellular level, so thank you, sir. And he described thrombosis and vascular effusion as the basis of ischemia. Now, modern wound healing in the 1960s and 1980s, this is very young still, researchers discovered that cells actually require low oxygen to trigger healing, and this shocked medicine. Healing doesn't begin with abundant oxygen, it begins with controlled hypoxia. Now, let's go through the definitions of hypoxia. So, hypoxia means there is not enough oxygen available for normal cellular metabolism. Blood flow may appear normal or may actually be normal, but oxygen delivery may simply be inadequate and cells become oxygen deprived. Ischemia means there is inadequate blood flow to the tissues. So we know blood carries oxygen, glucose, white blood cells, stem cells, growth factors, and antibiotics. And therefore, ischemia is much more than oxygen deprivation. It is nutrient deprivation, immune deprivation because the road is closed, okay? Waste removal failure. So, a simple analogy would be hypoxia is like receiving the delivery truck with an empty oxygen tank. So, let me just say that again. So, let's make it more relatable. Receiving the Amazon delivery truck with an empty oxygen tank. Okay? Now, ischemia is like the Amazon truck not arriving at all. Don't we hate that? So, physiology. So, normal oxygen delivery, heart starts from the heart, large arteries, the small arteries, then our arterioles, then our capillaries, then our interstitial space, and then cells. Oxygen diffuses into the mitochondria, which ends up would result in the ATP production, and then there we get to go healing, but that's just like a very scratched surface. So what happens during hypoxia? So imagine oxygen falls, blood flow remains normal, cells immediately detect the low oxygen. How do they detect that? Because we covered it yesterday. Hypoxia activates the hypoxia inducible factor 1 alpha. And this is how one of the master regulators of wound healing, normally oxygen destroys hypoxia induced factor 1 alpha. Low oxygen stabilizes it and it enters into the nucleus and turns on over 100 genes. Genes like VEGF, PDGF, EPO, GLUT1, nitric oxide synthase, angiogenesis genes, stem cell recruitment, and collagen remodeling. Hypoxia actually initiates repair without mild and nobody's asking you to strangulate anything, okay? Without mild hypoxia, that's what they're talking about, the occlusion dressing a little bit, okay, healing never starts. So when can hypoxia become dangerous? So mild hypoxia is adapted, and that helps with healing, mild, okay? Severe hypoxia, that will result in ATP depletion, which will result in lactic acid doses, which will result in membrane failure and which will result in cell death. Okay. So duration of the hypoxia matters and severity of the hypoxia matters. So what happens during ischemia? Remember, ischemia is like the Amazon truck didn't come arrive at all. And you're like, emailing contact support and saying, "Where is my package?" Okay? So, what happens during ischemia? Now, imagine an artery being blocked and immediately no oxygen delivery, no glucose, no immune cells, no antibiotics, no stem cells, no growth factors, no waste removal. And within minutes, ATP collapses, your sodium, potassium pumps fail, the cells swell, calcium floods inward, reactive oxygen species forms, inflammation explodes, and necrosis begins. So, why does diabetes make both worse? So, diabetes pretty much damages every level of oxygen delivery. So, we have macrovascular disease, macro, which is, peripheral arterial disease, where we have the large vessels blockage, which will result in actual ischemia. Micro, micro vascular dysfunction. This is where the capillary basement membrane thickening and there is poor oxygen diffusion, and that would result in hypoxia. So, neuropathy. Now, pressure goes unnoticed. So, tissue compression, because of the pressure going unnoticed, causes localized ischemia, which will result in an ulcer, right? And glycation, our advanced glycation products damage collagen, which causes damaged endothelial cells, reduce nitric oxide, and reduce angiogenesis. Now, hypoxia inducible factor 1 alpha dysfunction. So in healthy patients, hypoxia actually activates HIF, the hypoxia inducible factor 1, okay? And that helps with healing. In diabetic patients, when patients have hypoxia, they have a very weak response to activate the hypoxia inducible factor. Okay. And that would result in poor angiogenesis and a chronic wound. So, one of the biggest factors, one of the biggest diabetes problems is not just simply low oxygen, it is the inability to respond appropriately to low oxygen. So, what are some clinical clues that you might have a hypoxic wound versus a ischemic wound? So, mostly hypoxic wounds can be pink, granulation can be present, slow healing, warm, cap refill preserved, palpable pulses, and can bleed during debridement. Ischemic wounds, they're going to appear pale, gray, black, minimal bleeding, like I always said, when I see, like, you're in the OR and you're cutting and there's no blood, ooh, bad. Cold, delayed cap refill, weak pulses, pain at rest may be absent, possibly due to neuropathy, but, pain at rest. Gangrene, hair loss, remember we did the hair test, dependent rhubarb, shiny skin. Now, when it comes to diagnostic tests, I say agnostic, forgive me, diagnostic tests, we have our ABI, but we have to always remember diabetics frequently have calcified vessels. ABI may appear falsely normal. Our toe pressures, more reliable in my opinion. Healing generally requires greater than 30 to 40 mmHgs. So, transcutaneous oxygen pressure, right? One of the best predictors of wound healing, if it's 40 mmHg, that's very favorable for healing potential. If it's 30 to 40, that's borderline. If it's less than 30, that patient has poor healing potential, unfortunately. Now, our skin perfusion pressure, that assesses the microcirculatory blood flow. And generally, 40 mmHg is going to be adequate. Less than 30 mmHg is going to be impaired. Then we have a duplex ultrasound, which will evaluate the blood flow velocity and the stenosis. Your CT angiography or your MR angiography, which visualizes the artery anatomy, and then conventional angiography, which is gold standard when they're planning intervention that allows them to diagnose and endovascular treatment in the same procedure. That's why we love vascular. So, when there are going to be clues also during debridement. So, let's say you're doing sharp debridement, healthy tissue bleeds bright and red. I love it. Now, hypoxic tissue, it bleeds, but it also results in slow healing. Ischemic wound, almost no bleeding. That's a really bad sign. Great tissue, poor prognosis. If it doesn't bleed, you gotta ask why. And patients always get scared when they see blood. I'm like, no, this is a great sign. Like even when you're doing mechanical debridement with just your hand and you're scrubbing and it's bleeding, that is a good sign, because I remember one of my patients, she was just always so scared after healing, and it's like, "Oh, what happened if it bleeds?" I was like, "It means you're still alive, you're fine, okay? You're still alive, that means you have the ability to send the right signals and the cells and the recruitment and the immunes to help heal that wound, so it is good that you bleed, okay? No like, with a wound, okay? But it's not a bad thing. Treating hypoxia. Now, when it comes to treating hypoxia, we have to optimize offloading, nutrition, protein intake, glycemic control, infection management, moist wound healing, negative pressure therapy, skin substitutes, growth factors, cell-based therapies, hyperbaric oxygen therapy. But you have to remember the selection for these patients are particular, and they actually have their own indications for it, actual criteria for it. Correct edema and address anemia if it's clinically indicated. Now, you have to remember hyperbaric oxygen works best when blood flow actually exists, okay? It cannot overcome severe arterial occlusion. That's why we love vascular. We need vascular. No matter what, we're going to need vascular. Now, when it comes to treating ischemia, that's completely different. That's vascular is going to probably take that patient to the OR or other things, right? So, when treating ischemia, vascular is going to either do endovascular angioplasty, drug-coated balloons, stents, arthrectomy, pedal loop reconstruction, distal bypass surgery, hybrid procedures, aggressive PAD, risk factor modifications such as smoke cessation, lipid lowering, blood pressure and diabetes management, antiplatelet or antithrombotic therapy when indicated by current vascular guidelines, and only after perfusion improves does advanced wound therapies have the best chance to succeed. So that's another thing I do see. Everybody knows that I'm very like, no matter what baseline, it has to be baseline X-rays and baseline vascular. You need vascular. You need to know what your patient's vascular status is, because that gives you a greater idea of how they're going to heal. That really does. It plays a role. Everything plays a role, especially when it comes to diabetes, but it plays a huge role. That's why I love vascular. Say it 3 times. We need a vascular. Now, something called reperfusion injury. Ironically, restoring blood flow can actually briefly worsen tissue injury. So, sudden oxygen delivery that will cause reactive oxygen species, which will result in inflammation, which will result in cell damage, and which will result in edema. So, fortunately, the long term benefits of restoring perfusion generally far outweigh this transient injury. Now, when it comes to emerging therapies, researchers are exploring hypoxia-inducible factor stabilizers, like we mentioned yesterday, stem cell therapy, endothelial progenitor cell therapy, exosome therapy, nitric oxide releasing dressings, which is super cool, gene therapy targeting angiogenesis, bioprinted vascular skin constructs, oxygen generating biomaterials, mitochondrial targeted therapy. These remain areas of active research right now, and with some approaches available in clinical trials. That's why I always tell patients sometimes, a great option is a clinical trial sometimes, because even when I talk to some people in the past, like they'll be like, "Oh, my parent was in a clinical trial and they got so much better, but then when the clinical trial ended, went back to reverting to that pathology that they had." And it's very interesting to hear things like that because it's because it's a clinical trial. So let's do a quick case study. So 67-year-old male, type 2 diabetes, neuropathy, CKD, hemoglobin A1C is 8.8%, presents with a plantar first metatarsal ulcer. Also was existed for about 6 months, and he received 3 skin substitutes, 2 antibiotic courses, negative pressure therapy, hyperbaric, minimal improvement, okay? I mean, honestly, after hearing that, I already kinda know. Non-palpable dorsal pedal pulses, toe pressure is 18, transcutaneous is 16, okay? Angiography demonstrates severe tibial arterial disease. He undergoes a successful endovascular revascularization. 4 weeks later, the wound develops healthy granulation tissue. 3 months later, the ulcer heals completely. So the teaching point is advanced wound therapies were not necessarily ineffective. It was the inadequate perfusion was the limiting factor. So honestly, advanced wound therapies do have a hard time being successful if the patient has inadequate perfusion. So you have to always make sure that the patient has a good vascular assessment and that they have the ability to heal. Okay, because restoring blood flow really does make or break a wound healing's ability. So clinical pearls are mild hypoxia initiates healing. Severe hypoxia impairs healing. Ischemia deprives tissue of oxygen, not just oxygen, nutrients, immune cells, and waste removal. Diabetic patients often have both hypoxia and ischemia simultaneously. Falsely elevated abnormal falsely normal ABIs does not exclude PAD and diabetes. So always remember that. Toe pressures and transcutaneous pressure are often more informative in diabetic limb assessment. Hyperbaric oxygen is not a substitute for revascularization in severe ischemia. Not. Okay? And always evaluate perfusion before assuming a chronic ulcer simply needs advanced dressing. Okay? Hope that was very helpful for everybody. So in the end, I would do more questions, but hypoxia and ischemia are often spoken about as if they're the same process, but they're not. They represent two fundamentally different biological problems. Hypoxia is a shortage of oxygen that can actually trigger the body's repair machinery when it's mild and temporary. Ischemia is a shortage of blood flow that deprives the oxygen not just of the delivery, but of the nutrients, the immune cells, your growth factors, and the ability to clear metabolic waste. So in diabetes, impaired vascular function, neuropathy, chronic inflammation, the defective cellular signaling means that these two processes frequently overlap and creating wounds that are very difficult to heal. So the key clinical lesson is pretty straightforward. Before escalating to advanced wound therapies, make sure that the wound has adequate perfusion. That's why we love vascular. I love you, vascular. I'm such a fangirl. Understanding the difference between hypoxia and ischemia helps clinicians choose the right intervention at the right time and can be the difference between limb salvage and limb loss. So thank you for listening to Diabetic Fit Files. I'm Dr. G. Stay curious, keep questioning, and remember sometimes the most important treatment isn't just the dressing you apply, but recognizing that the tissue is missing something in the first place. And take care of your feet because they take care of you.